Thank you very much for inviting me to be a speaker in this important conference, Diabetes India 2022. And I'm going to talk about diabetes in the elderly. Life expectancy has been increasing. Advances in medical care and improved social conditions led to increased life expectancy. These are chronic health issues of older adults: arthritis, diabetes, hypertension, chronic sinusitis, visual impairment, osteoporosis, hearing impairment, varicose veins, heart disease, deformity, emphysema, dementia, and 34% of these older individuals are affected by more than one condition. Does the epidemic of diabetes involve older individuals or not? And the answer is yes. By the year 2050, there is going to be 336% increase in diabetic patients above the age of 75. The prevalence of diabetes, according to the IDF, is 8.8% of the total population, while according to the National Health and Nutrition Examinations Survey, the third one, in those above the age of 75, the percentage of diabetes prevalence is 17.5 to 21%. Diabetes in geriatric times is somewhat different as regards goals of therapy, choice of drugs, changed metabolism, and danger of hypoglycemia. Most studies show rise in blood glucose, especially the postprandial blood glucose, directly correlating with age. While the fasting blood glucose increases 1 to 2 milligrams per deciliter per decade, we find that the postprandial blood glucose increases up to 15 milligrams per deciliter per decade. And this metabolism change is due to impaired insulin release and delayed suppression of hepatic glucose output. We're going to talk about clinical presentation of diabetes in geriatrics. And what about the clinical presentation? And presentation may be confounding, and routine screening is recommended. It may be totally asymptomatic or having dramatic symptoms. The presentation may be with urinary incontinence, monoocular neuropathy, onset of sexual dysfunction, or minor and difficult to control infection. And let me now talk about challenges in management of type 2 diabetes in the elderly. Acute metabolic complications, diabetic ketoacidosis is rare, and features and management are the same like in younger individuals, but there is higher mortality due to associated cardiovascular disease. The hyperosmolar non-ketotic coma, 50% of cases occur in newly diagnosed diabetics, and it always occurs in older diabetics due to impaired maintenance of serum osmolarity, decreased thirst perception, and decreased access to water. Acute infection is a frequent precipitating factor in 40 to 60% of cases, and it's usually pneumonia. The difficulties in management are mainly due to rapid fluid replacement, which may not be feasible due to associated cardiovascular disease. Some underappreciated diabetes complications. Diabetes is a risk factor for dementia, increased 2 times dementia in the presence of diabetes, increased incidence of falls, hip fracture, immobility and disability, household work, preparing meals, managing money. And these are some diabetes complications in older individuals. Macrovascular disease, coronary artery disease is 2 times increased risk ratio versus non-diabetics. Stroke increased 2 times, amputation 10 times increased in older diabetic patients, and microvascular complications, blindness, 1.4 times increased than non-diabetics, renal disease 2 times increased, and neuropathy is markedly increased in older patients versus non-diabetic patients. Is there a risk of hypoglycemia or not? Yes, hypoglycemia risk is increased in the elderly and leading to impaired cognition. In older adults, they may have more neuroglycopenic manifestations of hypoglycemia like dizziness, weakness, delirium, confusion, compared with adrenergic manifestations with the symptoms of tremors and sweating. And these neuroglycopenic manifestations may be missed or confused as primary neurological disease, such as transient ischemic attack, leading to inappropriate diagnosis and management. Hypoglycemia is a major challenge in the treatment of diabetes in the elderly, and it may happen due to patient risk factors, advanced age, intercurrent illness, chronic liver disease, renal disease, or cardiovascular disease, endocrinal deficiency, thyroid, adrenal, or pituitary, loss of normal counter regulation, and hypoglycemia unawareness. It may happen also due to lifestyle risk factors like poor nutrition or fasting, prolonged physical exercise, or alcohol intake. And the third group is the drug risk factors, the use of sulfonylurea or insulin, the drug interactions with sulfonylurea. Severe hypoglycemia account for 17% of all hospitalization for type 2 diabetes in the elderly. Let's talk about chronic complications of diabetes in the elderly. Neuropathy is the most common symptomatic chronic complication. There is a progressive course with limb amputation, and the clinical diagnosis is often difficult due to age-related peripheral and autonomic dysfunction. Diagnosis is based on nerve conduction studies, and bladder dysfunction is common, but it has to be differentiated from senile enlargement of the prostate, and both conditions may lead to urinary tract infection. Geriatric diabetes is having some unique syndromes: diabetic amyotrophy occurring in older male diabetics, malignant otitis externa, which is a necrotizing infection, usually caused by Pseudomonas, pyelonephritis with papillary necrosis, diabetic neuropathic cachexia with weight loss, depression, painful peripheral neuropathy, and it resolves without specific treatment, intradermal bully of the feet, periarthritis, and increased risk of accidental hypothermia. What to do for management of diabetes in the elderly, and according to ADA 2021, and to consider the assessment of medical, psychological, and functional self-management abilities of the elderly diabetic and social conditions, who is going to help these diabetics at home to decide the therapeutic approach for diabetes management, and to screen for geriatric syndromes like polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain. These may affect diabetes self-management and diminish the quality of life. To screen for early detection of neurocognitive impairment or dementia should be performed for adults 65 years of age or annual visits after 65. And the management, we have two series. One series of the postprandial blood glucose of 200 milligram per deciliter, and another series of euglycemia with hemoglobin A1C less than 7%, and what to choose. And according to life expectancy and current medical conditions, goals should be individualized according to the ADA and different other guidelines. The treatment goals for older individuals who are otherwise healthy with few coexisting chronic illnesses and intact cognitive function, they have lower glycemic goals from 7 to 7.5% hemoglobin A1C. For those with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence, we should have less tight glycemic goals from 8 to 8.5 hemoglobin A1C target. For patients with relaxed target, for patients with end of life or morbid conditions or life-threatening conditions, we may have less tight glycemic targets. Screening for diabetes complications should be individualized in older adults, and particular attention should be paid to complications that would lead to functional impairment. These are the framework for considering treatment of glycemic control, the blood pressure, dyslipidemia in older adults with diabetes. When to use the statin, and this is the ADA 2021 guidelines. For lifestyle management, optimum nutrition and protein intake is recommended. Regular exercise, including aerobic activity, weight-bearing exercise, or resistance training exercise should be encouraged. For adults with type 2 diabetes, with overweight and obesity, there's a need to lose weight if possible with physical activity and dietary changes. This is the Canadian guidelines 2018, and the hemoglobin A1C targets for most type 2 diabetes should be less than 7% in adults with type 1 or type 2, and less than 6.5 in adults with type 2 to reduce the risk of chronic kidney disease and retinopathy if at low risk of hypoglycemia. From 7.1 to 8% in functionally dependent older diabetics, and from 7.1 to 8.5 in those with recurrent severe hypoglycemia or hypoglycemia unawareness, limited life expectancy, or frail elderly with or without dementia. And to avoid higher hemoglobin A1C, to minimize the risk of symptomatic hyperglycemia and acute and chronic complications. End of life A1C measurement is not recommended, but to avoid symptomatic hyperglycemia or any hypoglycemia. Diet, it is difficult to adhere to strict dietary regimes due to financial difficulty, mobility problem, poor food preparation skills, and long-standing dietary habits. No restricted diet is needed, but vitamins and minerals should be taken if the caloric intake is less than 1,000 kilocalories per day. Sulfonylurea, the clear and present danger, hypoglycemia with no warning symptoms. For biguanides, it should be used in cases without renal insufficiency or hepatic disease, contraindicated in alcoholism, severe cognitive congestive heart failure, and severe peripheral vascular disease. Alpha-glucosidase inhibitors, they are safe, but may lead to severe gastrointestinal disturbance. Sazolidine-diones, there is a fear of a precipitation of heart failure. The incretin-based therapy, DPP-4 inhibitors are safe with no risk of hypoglycemia. They are weight neutral, therefore may be attractive agents to use in the elderly, and the dose of DPP-4 inhibitors should be adjusted according to renal insufficiency if present or not. The GLP-1 receptor agonist, no risk of hypoglycemia, with the known adverse events of nausea and vomiting and diarrhea may happen. The SGLT2 in elderly patients, according to study done on dapagliflozin, there was no serious adverse events in older individuals, except for volume depletion. The Canadian Diabetes Guidelines, again 2018, for older patients, DPP-4 inhibitors should be used over sulfonylurea, and the initial doses of sulfonylurea, if given, should be half of those used for younger people, and doses should be increased more slowly. Glyclazide and glyclazide MR and glimepiride should be used instead of glyporide, and meglitinide may be used instead of glyporide. What about insulin therapy in geriatric times? There may be possible medication error due to visual impairment, impaired manual ability, and limited access to injection sites. And insulin analogs seem to be more safe for geriatric people living with diabetes. By the end of my presentation, let me introduce Mr. Diabetes. Mr. Diabetes is an American patient living with diabetes, and he has gone through different US states walking and on a bicycle, and due to his exercise, his neuropathy has disappeared. Thank you.